Good afternoon. Thank you for joining us for our bi-monthly webinar that is held at the behest of NANT and the American Society of Diagnostic and Interventional Nephrology. We're delighted today to have Bharvi Oza-Gajera, who is an interventional nephrologist and associate professor of clinical and internal medicine at the College of Medicine at the University of Cincinnati. And I'm going to stop my share. And Bharvi, if you could start your share, and then you can begin.
There we go. Does that work for everybody? All right. Well, thank you so much for the very kind introduction. I am Bharvi Oza-Gajera. I'm an interventional nephrologist here at the University of Cincinnati, though most of my clinical work in the access realm is done at an access center with a private practice in town, the Dialysis Access Center of Cincinnati. I've been working in the vascular access space for the last 12 years, and it is certainly a passion. So I am very honored to be invited here today to speak to all of you about access monitoring. So on a webinar, it is a little bit formal just because I can't see everybody, but feel free to jump in with questions. I will try to periodically check the chat. I'll try to put it over here to the side. So I'll try to keep an eye on that. But if I miss something, feel free to jump in and ask any questions as they come up, because it might be easier to answer as I'm on a topic. But of course, if you don't remember till later, I do have time at the end to take questions. So we're going to be talking.
Can also, excuse me, Bharvi, people can also use the raised hand function in Zoom.
Yes, yes. And if I don't see that, please let me please let me know. So I'm going to be talking about vascular access monitoring, fistulas, grafts, and tunneled dialysis catheters. And the learning objectives here are to discuss the 2019 KDOQI guidelines for vascular access monitoring, and then to review the 1-minute checks for access monitoring. So the 1-minute check for AV fistulas, for grafts, and for hemodialysis tunneled catheters, so the permanent ones. And an outline, sort of a brief outline so you know what to expect. I'm going to go over some anatomy initially because I think there are people from all levels of their career and some might be relatively new. So I just want to review the anatomy so that we're all on the same page when we're talking about vascular access. Then go through dialysis vascular access modalities because there are a couple, and then go through the guidelines from the KDOQI, and then go through the 1-minute checks, the weekly maintenance checks for each of those modalities, the catheter checks, maturation checks for a brand new fistula, and healing checks for a brand new insertion of an AV graft. And then I do want to end with a couple AV access emergencies, namely impending hemorrhage, because it is so important and it can save a life. So if we're talking about the anatomy involved, one second here, let me just change that. Okay. We're talking about the superficial veins. So the superficial veins in the arm include the cephalic vein in the forearm and the upper arm, and the basilic vein in the upper arm. So these are the light blue kind of vessels that you see here. So the cephalic vein right there, it goes into the cephalic in the upper arm. And then as you notice, that basilic vein in the upper arm actually lives between the two muscles in the upper arm. And that's why that one needs to be transposed and has to be raised up closer to the surface when a fistula is created so that it can actually be accessed. When we look at the arterial side over here, we're looking at the radial artery right there, and then the brachial artery in the upper arm. So when we're talking about vascular access, we're talking about arteriovenous fistulas, arteriovenous grafts, and an HD catheter. And these are always named in the direction of blood flow. So radiocephalic fistula is a radial artery to a cephalic vein fistula, and that's at the wrist. Then a brachiocephalic fistula is a brachial artery to a cephalic vein in the upper arm. And then brachiobasilic is a brachial artery to a basilic vein also in the upper arm. And the same thing with grafts. It's all named in the direction of blood flow. So here are the three that I just mentioned: the radiocephalic, the brachiocephalic, and the transposed brachiobasilic. So here you can see where there's that surgical scar underneath the arm where they've lifted that vein from its native location and transposed it closer to the surface of the skin so that it can be accessed. When you're kind of looking at someone's arm and their access, if you don't notice that scar, this can appear very often similar to a brachiocephalic. But what's important to note here is that there are two swing segments. So there's a swing segment right where it's sewn into the artery, and then another where it's sewn into the vein. And that's where they've literally had to swing up that vein closer to the surface. So both of those points can be points of narrowing that can cause dysfunction, which you will feel on an exam. So again, these are the different types of configurations of an AV graft. These are all made out of PTFE material, and they're named, again, in the direction of blood flow. So a forearm looped graft here is from the brachial artery. It can actually be to the basilic vein like it is here, or to the cephalic vein, or to the median cubital, kind of down further in the elbow. Either of those three locations are possible for a forearm looped graft. And then an upper arm straight graft goes typically from a brachial artery to the proximal basilic or axillary vein. And an upper arm looped graft is from the axillary artery to the axillary vein. Something to note here too is some of these loops in the upper arm, the bottom sort of limb of that loop can be really tucked under the arm, because when the surgeons have these patients' arms out on a table, the patients are sedated and they typically have a nerve block to the arm. So their arm is a lot more mobile than it is naturally. And for them, when they have it laying out and kind of splayed, it looks like it's a great place to tunnel a graft. And then when they go back to their normal lives, it's really tucked in under the arm there. So a lot of times it can look like it's a straight graft just like this, because the other piece is kind of tucked under the bottom side of their arm there. And then a femoral loop graft is kind of a last resort access that can be placed in patients who need them, but luckily we don't see them quite as much, at least in this area. So I do want to kind of discuss a hero graft really quickly, because they are around, and these are kind of dependent on surgeons and locale of where you're located. In our area here locally, we have quite a few heroes, but you have to have a surgeon who's willing to put them in. And what this typically is it's two portions. It's got a portion from the artery up here to a connector piece, and that's a regular graft portion, and that's the portion that you stick and cannulate. Then it's got a connector piece, and then from here back through the vein and into the heart, it's a nitinol mesh piece. So it's actually a metal piece that connects to the graft. And this part you never really access. That kind of stays under the skin. It's never stuck, but this part is what you cannulate. And these are put in patients who have had prior accesses that have been exhausted and they have central stenosis. So they're able to get a catheter in, but they're not able to support a fistula or a graft in the arm because of a narrowing or stenosis that they have somewhere up here in the central vasculature. If they're able to get a catheter in, they're able to put in a hero graft. The one thing to note about this, as you look at this picture, is that this is a very long conduit. So patients who have lower blood flows or who have blood pressures that drop during dialysis or typically live at lower blood pressures tend not to do as well with heroes, because they'll clot very easily just because you have to have enough pressure going through that system to run through this entire conduit. So that's something to kind of keep in mind. If you have a patient that has a hero, kind of watch that blood pressure. And if they're running low and you feel like, oh, this is kind of soft and I don't think that it's as strong as it was before, you are correct. And then we have our catheters, sort of necessary evil. They work immediately, they often work well. But we all know the issues with catheter, including infection and stenosis. But what I did want to point out here, the fabric cuff that is right there is what holds the entire catheter in place. So when it is inserted, that cuff is 2 to 3 centimeters higher than the exit site. So higher than where you see that catheter coming out. That's where that cuff is. And that cuff is what holds the whole catheter in place. But also that cuff is what keeps that entire catheter sort of clean and relatively sterile from here all the way back to the bloodstream. So it creates a barrier to all the flora from the outside. So here's kind of a picture of the catheters in place. This is non-tunneled. This is not what we see in the outpatient world, but in the hospital, for those of you who still are in hospital settings, you'll see this for acute patients or patients who are having things done. So the non-tunneled catheter kind of just sticks out of the internal jugular vein here. But tunneled, it's in the same vein. The same vein is where you puncture to put these in, but then you turn it under the skin from here to here, and that's all under the skin in the subcutaneous tissue. And the cuff sits right there, just past that exit site. And I do want to point out here that nomenclature is actually very important. We very often see people kind of labeling catheters as a subclavian catheter. That is erroneous, and it can actually lead to some negative ramifications for the patient. Almost all of these, I would say 95% of them, are in the IJ. They're in the internal jugular vein, sometimes in the external jugular, but that will be very clearly identified in the procedure report. And very, very rarely, they basically have to have exhausted everything else for it to be in the actual subclavian vein. And the reason for that is that if you place a catheter in this subclavian vein, it does stenose. It develops a stenosis right at that subclavian vein. And now you have forsaken that patient to not ever develop an adequate fistula or graft on that side, because they're going to run into that stenosis quite often, if not always. So that's just a point that I wanted to make. So shifting gears just a little bit, I want to discuss the KDOQI 2019 Vascular Access Guidelines. So these are guidelines put out by the National Kidney Foundation, so the NKF, which has a sub-organization called the Kidney Disease Outcomes Quality Initiative, and that's what KDOQI stands for. And the KDOQI puts out evidence-based guidelines for hemodialysis vascular access, and it has been doing so since 1996. And in 2019, there was an updated set of guidelines that were published, essentially providing optimal practice guidelines for multidisciplinary professions working in the field. So this is for not just techs, but nurses, nephrologists, surgeons, interventionalists. Everyone in the space who touches avascular access can go to these guidelines and look up things that are specific to their purview. It's basically the gold standard of care for ESKD patients. So for monitoring, the guideline is 11.1, and that guideline is that the KDOQI considers it reasonable to assess or check the vascular access or surrounding area by physical exam prior to every cannulation if it's an AV access, or every connection if it's a catheter, for potential complications. And I want to emphasize here that this is every single treatment. So every time a patient comes in for a treatment, before they're cannulated, before they're connected, there needs to be an assessment done, a physical exam done of the access itself and the surrounding area. And I do want to emphasize that this is different from the monthly blood flow evaluations. So we evaluate these accesses with monthly measurements, usually transonics or venous pressure measurements done at a certain level of blood flow. This is not that. This is the routine, quick, let me assess your access and make sure that there isn't a problem before I stick you or connect you. And if there is a problem, to be able to discern, is this a problem that can wait, that we need to refer you out for, but we can still treat you today? Or is this a problem that you need to go into the hospital now because this is not something that we can wait on? And the entire crux of this conversation is to improve the life of the vascular access and therefore of the patient. And yes, the patient has a nephrologist and a surgeon and an interventionalist and nurses who are all involved in their care. But quite honestly, all of you as the technicians are the people that are in the trenches with these patients. You interact with them the most, and you really have so much power and influence and potential to shape their lives and the functionality of their vascular access. And that ends up leading to an improved quality of life. And I really do want to emphasize that because there is objective research and data that proves that having a reliable and functional AV access does lead to improved quality and quantity of life for these patients. So realize your potential because you really do have a lot of influence. They listen to you, they listen to your comments when you're talking about their access, they're listening. So the KDOQI guidelines also state that clinical monitoring strategies include a physical exam, which involves inspection, palpation, and auscultation of the vascular access to detect signs that suggest the presence of pathology. And I want to throw this up here. This is a really busy table, but this is the table that's presented in the guidelines. And I wanted to include it just so everybody has it. It is very thorough and very detailed. And we will go through all of this kind of in a piecemeal fashion, but I did want to include it as something that was kind of a go-to slide to refer back to if or when you need to. So because evaluating AV accesses is different from evaluating catheters, I wanted to point out this statement from the KDOQI as well. So vigilant CVC care, central venous catheter, is required, including regular inspection of the CVC, the tunnel, the exit site, and adherence to CVC care protocols. And we'll kind of go through all of this, but you always want to start furthest away from the insertion point. So if you're looking at the catheter, you take a look at the part that's external, the hub and the two ports that you're about to manipulate, and you look at the exit site and the actual exposed part of the catheter. You ensure that the caps are on and appropriate, check for any leaks, any residue or glue from the tape, just that gunk that kind of builds up around those two ports and underneath that hub that's in the middle. Take a look at the skin, make sure that it's not looking red or irritated. Sometimes it's not necessarily infected, but the tape is having a reaction to the skin. So you want to kind of take a look at all of that. Then you look at the exit site itself where the catheter actually comes out of the skin. Another thing I want to point out about the exit site is that there are often sutures either at the exit site or at the stay wings of the catheter, sometimes both, and those need to come out. Usually 2 to 3 weeks, unless it's specified. Every so often we'll have a patient where we say, you know, why don't we leave them in for 4 to 6 weeks because this patient keeps coming in because their catheter keeps falling out. But otherwise, 2 to 3 weeks is fairly standard. And I cannot tell you the number of times I've seen patients come in for a catheter removal or a catheter exchange. It's been in for months. I had a patient last week who had had his catheter in for 2 years and the sutures were still in. And what happens is that those sutures will get embedded into the skin. It can cause a lot of irritation and itching, and it can get, the sutures themselves can get infected. Not to mention it's much harder to get them out, and it's much more painful to get them out once they're embedded in the skin. So be cognizant of the fact that there are sutures there and kind of look up when they were put in and when they need to come out and be aware of that. Check for any drainage or redness, erythema, tenderness, anything along that exit site and the tunnel leading up to the venotomy that seems like it might be something worth looking into further. The tunnel is the portion of the catheter that is in the subcu tissue from the exit site, but not yet into the blood vessel. And this area can get infected. So that you need to kind of be aware of and take a look at and palpate, make sure that it's not tender. You can feel for that cuff. So that fabric cuff that's underneath the skin, you can feel that. And you just kind of rub your finger up and down over it, and you can feel that cuff. So you know where it is, and then you can assess if it has moved. A lot of times, if someone's catheter gets tugged a little bit, the cuff isn't exposed quite yet, but if you're feeling for that cuff every single time the patient comes in, you'll know if it's moved further down and the patient needs to get their catheter replaced because of that before that cuff is exposed. And then finally, follow the catheter track up to the base of the neck. Usually it's right above the collarbone, and this is where the catheter turns and goes into that internal jugular blood vessel. And you want to just kind of feel for that there too and make sure that there isn't anything there that feels abnormal. So what does all of this mean? What does it mean to do a vascular access exam? And really, most importantly, what's the purpose? Why are we doing this, and why do we need this every single treatment? So I'll start with that second point first, and then we'll go through the first point in a little bit more detail. So honestly, we're trying to avoid cannulation injury. So avoid any injury that occurs with the needling of that access. And the best way to do that, that's been studied, is to do these 1-minute checks. It's a quick assessment of the patient's access before you actually try to go and stick that patient. And the reason we want to avoid cannulation injury is because oftentimes, once someone has an injury, their access is kind of changed. Not always permanently, but quite often. You can get a bad infiltration and it can cause edema that the edema resolves, but the access gets pushed a little bit to the side, or they develop scar tissue that ends up being problematic. Or even if it's not problematic, it still affects the blood flow rates. So we really want to try to avoid cannulation injuries. We also want to identify any access emergencies before cannulation. So if there is some sort of emergency or something that just does not look right, we want to get that patient to someone else who can fix it, either via the emergency room in the hospital or to an outpatient surgical center, so that those emergencies can be identified and corrected before that patient is cannulated. So those would be things like identifying infection, impending rupture, any sort of aneurysm that seems unstable. All of those things would need to be referred, and you should not cannulate those patients. So you also want to develop a working knowledge of that particular access so that you can identify a change. So if you're not used to looking that access every single time the patient comes in, you're not always going to pick up on subtle changes. But if you have been looking at it just for a minute every single time that the patient comes in, even subtle things you'll start to pick up on. And when you see those subtle things, they might not be a problem today, but it keeps getting worse. And by next week, it's something that you know you need to escalate care for. You'll also want to catch pathology before the access becomes dysfunctional. And the biggest kind of crux of all of this is that you don't want to lose an access to thrombosis. We really want to avoid thrombosis of a fistula or a graft. It is much, much easier to do a procedure on a graft or a fistula that's flowing and has blood flow through it than a clotted one. And also, the risks that come with declotting a fistula and a graft are much higher. These patients end up having that done multiple times throughout their lifetime, and they develop pulmonary hypertension and other cardiac and pulmonary issues that are chronic issues that occur because of these repeated procedures. So we're really trying to avoid that for them. So going back to the physical exam, the KDOQI recommends the 1-minute check, and these were developed as part of the Fistula First initiative as an easy way for anyone on the care team, as well as the patients themselves, to be able to quickly, efficiently, and effectively check their accesses. So it only takes 1 minute, and you can do it in the fistula, in the graft, as well as the catheter. And it's basically a look, listen, and feel approach. So essentially, you're doing an inspection, you're auscultating, and you're doing a palpative exam, but it's easy to remember as a look, listen, and feel. And again, it takes less than a minute, and it has been proven to be effective when done every single treatment. And I highlight that it has to be done every single treatment to be effective. So I'll go through the 1-minute check for each of the various dialysis axes. The fistulas are first. So for a fistula, you want to look, listen, and feel, and then do an arm elevation test. And I'll go through each of these here. So the first step is to look. So you want to inspect the entirety of the fistula and the skin around it. And if this is in the lower forearm, make sure to take a look at the entire arm, including the upper arm, underneath clothing, as well as the hand itself. You want to take a look at the hand also and make sure that it's well perfused. If it's an upper arm fistula, especially a brachiobasilic, make sure that you're looking at the armpit and the axilla too, taking note of anything abnormal, because anything underneath there that's abnormal is going to be related to the access in that upper arm. You don't want to see hypopigmentation, so changes, especially in pigmented individuals. If you see loss of that pigment, that's a problem. You don't want to see any erythema or redness, certainly no drainage. And then if there are any lumps and bumps, you want to make sure that you take note of them so that you can see if they're getting bigger, smaller. Are there any that are new? Is there anything about them that's notable? Kind of want to note all of those things. And that's basically what they're mentioning here. If there are any skin bulges, anything shiny, bleeding, or peeling skin, those last three, the shiny, bleeding, and peeling, you immediately want to stop, because those patients should not be cannulated. You need to escalate those patients to figure out where they need to go next. So that's the look. The listen should be a hum or a buzz, and it sounds kind of like a whoosh. It sounds a little bit like a drum beat, and I've got a sound here in a second. I just want to kind of go through this slide, and then I'll see if I can pull that up for you. So this is where you want to start at the scar. So the anastomosis, or point of hookup, where it's hooked up to the artery. You start with your stethoscope there, and then you move away from the hookup. And it might get softer as you move towards the shoulder, but that's normal. You just want to make sure that you do that every time so that if it changes, you can catch it. And certainly if there's no sound or decreased sound, that's a problem, but change is really what you're looking for. The sound is different from a normal bruit. So I am going to pull up a normal here. So that is a normal fistula. And then here, this is a stenosis. So you can kind of hear how sharp this is, kind of compared again to the normal. There we go. So that's kind of a whooshing, and the other is more of a sharp kind of whistle sound. So that's the difference. And once you start listening to the same patient over and over again, you will notice a difference if something changes. And then the third item is feel. You want to palpate. And again, I always recommend starting at the scar because it's just easy. You know, you can see the scar. It's usually kind of right where you don't want to go when you're looking at where you're going to cannulate. So it's easy to start there. And that way you're kind of doing it the same way every single time. So start at the scar, the hookup, and move upwards from there. And it should be most pulsatile at the hookup because that's where the artery is. But immediately thereafter, as you move towards the shoulder, it should be kind of a light buzz. And that's that thrill. It's a vibration or a buzz in the full length of the access. And the pulse, it's going to be a little bit pulsatile throughout because it is arterial blood flow, but it shouldn't be sharp. If it's sharp, then that means that beat is stronger, and it's basically that arterial beat that's being carried through the fistula, and that means that there's likely a stenosis in the outflow. I will also add here if the patient has aneurysm. So if you're doing a palpation exam, you're feeling the fistula, and the patient has aneurysms, try to lift the skin up over that fistula. You should be able, the skin overlying that fistula should be pliable and easily movable, and you should be able to feel that vessel underneath. If that skin is so tight over the fistula that you cannot pick it up, then that is a surgical emergency, because that means that there is no give at all. And if that patient were to rupture, they would potentially bleed out if they couldn't get to the OR fast enough. So do not stick something like that and send them immediately to surgery via an ambulance through the ER. And this is the final step of the mature fistula check. So an arm elevation test. So it's basically just as it sounds. It's to detect an outflow stenosis, and you just raise the arm up. If there's a narrowing, let's say there's a narrowing up at the shoulder and the fistula is down at the wrist, when you raise that arm up, that blood is just going to kind of be stagnant where that narrowing is, because it's the path of most resistance, so that it's going to fill up the entire fistula and it'll stay kind of plump and taut throughout the entire arm. And when you lower it, nothing will really change. But if there is no stenosis at all, when you raise that arm, the fistula will collapse completely. And you can kind of feel it too, especially if there's some stable aneurysms there. If you kind of palpate and press on those aneurysms, you can collapse those very easily. And that's a really good sign that there is no outflow stenosis. And I am going to try again to show you that here. Here we go. Let's see if I can get this.
Fistula.
In this video clip, the arm with the radiocephalic fistula is seen in the horizontal position. There's a small aneurysm at the wrist.
So you can tell, there it goes, there it collapses. You can tell kind of right here.
The fistula collapses, or the aneurysm flattens out completely.
See how it goes down all the way?
The arm is raised.
And then when he puts his arm back down,
the arm is lowered.
It plumps back up again.
The aneurysm fills up, fistula fills up, and it appears distended.
So that is exactly what you see when you do an arm elevation test and it's negative. There's no outflow stenosis. So the 1 minute check says that the augmentation test is optional. So everything in all of AV access is a circuit. There's inflow and outflow. The arm elevation test is to check the outflow. The augmentation is to check the inflow. Now the inflow is a little bit harder to check and to kind of wrap your head around, which is why they say it's optional, because sometimes it's kind of hard to get a feel for it. But if you do it often enough, it does get easier. And this is where you basically hold pressure. You know, if you have the entire, let me show you on this picture. If you have the entire access here, you occlude here. And if you're occluding the outflow, you're basically creating an outflow stenosis. So that artery, the pulse from the artery then gets pushed all the way through this part of the fistula. So if you're, this finger right here is just lightly resting right on top of that fistula. This one is applying pressure and occluding. So you will feel a pulse here if this inflow does not have a narrowing or stenosis. If there is a problem here, then you won't feel any change when you put pressure here or not. And I will try to see if I can show you that here as well.
This video shows how to perform the test. For best results, you should follow the instructions in the video precisely.
The augmentation test. The augmentation test is performed to assess the adequacy of inflow pressures. The animation clip shows the radiocephalic fistula. The first part of the animation shows a normal augmentation test. The outflow vein is manually occluded, few centimeters proximal to the anastomosis.
Right there, and you feel this.
Between the arterial anastomosis
This is
and the occlusion
all flowing normally
because of the arterial pressures transmitted across the patent anastomosis.
So if there's a narrowing here, You
the
don't
stenosis
get as much
in
of
the
an
segment.
augmentation, which is why it's
The
called
arterial
the
pressure is
augmentation.
not adequately transmitted, and the segment between the occlusion and the anastomosis remains weak.
So that's the augmentation test. Again, it's optional because it is a little bit more involved. So if we switch gears a little bit to grafts, it's essentially the same as the fistula. It's just a teeny bit different because the anatomy is different. So you have to know which way the blood is flowing. And the easiest way to do that is just to figure out where the middle of the graft is and occlude it completely and then feel which side has a pulse. Is it the top part or the bottom part? And then you'll kind of know where the blood flow is coming from. So you want to look at the entire graft, make sure the skin is all one color, make sure that all the skin around the graft is one color. There's no redness, there's no swelling, there's no discharge or anything like that. And then you want to listen. And again, I always start at the arterial side and at the scar and then work all the way around the entire graft and go to the outflow where it's hooked up to the vein. Grafts notoriously have more problems on the venous outflow side. So that's usually the side that's always causing problems. So that's where you're going to hear those kind of sharp whistles or the sharp pulsatile flow when you're feeling. It's typically almost always on that venous side. If you're feeling anything on the arterial side, then there might be something within the graft that's causing that. So you want to feel the whole thing, but pay particular attention to that venous side. And I also want to point out here that pseudoaneurysms, so they look just like aneurysms, they're pseudoaneurysms because they're coming from a graft and not from a native vessel. Do not stick those. That basically is graft material that has weathered away, and there's just a hole in that graft that's causing blood to kind of come up and around. And there's nothing but skin and a little bit of subcutaneous tissue that's holding that blood flow in place. So you really do not want to stick anywhere near a pseudoaneurysm. You also, again, want to make sure that that skin is mobile right above it, and so that it's not so tight that it's an impending rupture. And those in grafts, they've come from puncturing the same site repeatedly, because if you're going into that same site over and over again, that graft doesn't have time to close on itself, and it develops a smaller hole that becomes a bigger hole that then becomes that pseudoaneurysm. So you really want to avoid that. And then catheters. So the catheter look, listen, and feel is also a little bit different because it's a catheter. We kind of went through the entire look portion earlier. The listen here is not listening to the catheter, but it's listening to the patient and listening to the patient telling you that they may have a fever, that they've noticed something different with their catheter, that it feels different, that it looks like it got pulled down or something like that. So those are all things that you have to listen to. You're listening to the patient. And then we kind of went through the feel for the catheter as well already. So when we're talking about flow dysfunction in a fistula or a graft, we're really looking at a conglomerate of symptoms, not just the exam, but the exam includes a pulsatile fistula or graft. And then the other components are a low KT over V that indicates recirculation, prolonged bleeding after you take the needles out. The patient usually only requires a 3 to 5 minute hold, and now all of a sudden you're having to hold for 10, 15 minutes, or they have breakthrough bleeding. Those are always problematic and need to be assessed. And then high venous pressure. So those are all signs that something is going on with this abscess. And here again is a table from the KDOQI guidelines that kind of goes through a physical exam that has issues. So ipsilateral extremity edema. So you're taking a look at both arms. One hand is twice as large as the other hand. There's an outflow stenosis in there somewhere. Alterations in the pulse with a weak or resistant pulse, difficult to compress in the area of stenosis, an abnormal thrill, an abnormal bruit, failure of the fistula collapse when the arm is raised, so a positive arm raise test, lack of pulse augmentation, again, that's the inflow stenosis, and then excessive collapse of the venous segment upon arm elevation. Those are all the physical exam checkpoints that you kind of want to be aware of as things that you might run into in an access that is having some problems. So what about a maturing access, an access that just got put in, we're not using it yet, we're still using the catheter, but the patient has it? This should be assessed every single dialysis treatment as well. You should always be looking at a brand new access because those first few weeks are really important. And those are going to be when most of the information you get is going to determine whether that fistula is going to make it or not. So the first 1 to 2 weeks, you want to make sure that you're looking at the skin, making sure that the surgical site looks clean and dry. Everything's one color. It looks like it did before surgery. At that point, especially in a fistula, but a graft also, you want to take a look at the hand and make sure this is a brand new access that has gone into this patient. You want to make sure that they've got good perfusion in their hands and that they're not having such blood flow stolen from the artery that they're not getting enough perfusion to that hand. You want to listen to it. You should be able to hear it. I mean, when they create these fistulas in the OR, they're listening to them with a Doppler in the OR. So you should be able to hear it within that first 1 to 2 weeks. If you're not hearing anything, then most likely it's clotted or never developed. And then start feeling it. And it will be soft at first, but over the weeks, it will get stronger and stronger. And that's kind of what this slide here shows. So this is week 3. Basically, it's the same thing, except the pulse is stronger. And then you add the arm elevation test. So weeks 1 and 2, you look, listen, and feel. Week 3, you look, listen, and feel, and add the arm elevation test. Make sure there's no stenosis in the outflow segment. Week 4, again, you do the same look, listen, and feel. This time you do the elevation test as well as the augmentation test. You want to make sure that it's augmenting. So fistulas that fail, primary failure rates are typically because there's a stenosis right there at that inflow. And that's usually because when they are creating that anastomosis, they have to clamp the vein and clamp the artery while they're sewing the two together. The artery tends to handle it a little bit better because it's muscular. The vein does not. And often we will see that where that vein was clamped during that anastomosis creation, there's a stenosis that develops. And that is so close to that anastomosis that the rest of the fistula doesn't get enough blood flow to develop. You can assess that by week 4. We typically don't intervene on it until week 6 because you want to make sure that that anastomosis is really strong before you put a balloon in there and dilate it. But you can pick it up at week 4, get the patient scheduled at week 6, and get it going because it does take time. You have to do that procedure, let it rest for 2 weeks, take a look again, possibly do another procedure, and then take a look 2 weeks after that. So it is kind of a process. So if we're switching to graft healing, so this is a patient who has had a graft inserted into their arm. What do you look for? Grafts are ready to go really as soon as the scars are all healed. You just want to make sure that that tunnel is kind of in place and that there's not a lot of swelling around it and that the scars from the actual insertion site are all well healed before we go starting to stick a graft. But other than that, they're pretty quick to use. Usually by week 3, they're ready to go, most often by week 2. So I know this says weeks 2 to 3 here. It's actually the same thing, but the week 1 didn't have this bottom part and I wanted it all on one slide. So for week 1, you want to look, listen, and feel the same types of things as a fistula. You want to take a look at that graft, make sure all the skin is the same color. There's no redness, there's no drainage, the hand looks good. You want to listen to it, make sure it sounds good all the way through, and you can feel it. A graft is a graft, so it doesn't have to develop. You'll feel it right away. It should be ready to go from that standpoint. You should be able to feel the thrill and feel a light pulse. If you can't, then there's a problem. And then at week 2 to 3, you can do the augmentation test on that graft to make sure that it's strong and bounding and that it's got good inflow going through it. I do want to mention that aneurysms and steel are things that we have to be cognizant of. I think the next webinar is going to cover most of those, so I did want to put that in there. And then for anybody who wants to take a look at cuff migration, it's on page 110 of the Kadoki guidelines. It's guideline 20. That's talking about the cuff from the tunnel dialysis catheter. If you see that cuff coming out of the exit site and it's migrated down, that entire catheter needs to be replaced immediately and the patient should be given prophylactic antibiotics. But I do believe that's going to be covered in the next webinar. I just wanted to mention both of those things. And then lastly, I did want to spend just a couple minutes talking about impending hemorrhage before we get to questions. So there is actually quite a phenomenal campaign in the UK implemented by Kidney Care there, where they gave everybody keychains. They kind of see up here. It's a keychain with just a bottle cap on it. And the whole idea is that you take this plain bottle cap, and if you have any bleeding at all, you just take the bottle cap, put it right over the site of bleeding, and it does bleed into the cap, like you can see. So you put it on right there, it bleeds into that cap, but then it tamponades, and it's much easier for a patient or for anybody in the care team, honestly, to hold down a bottle cap than it is to try to find the exact source of bleeding and hold pressure over it. You know, at that point, I'm sure you all have seen there's kind of blood everywhere. It's messy. You're trying to act quickly, and it's hard to sort of tell where everything is. Yes, you can hold at the anastomosis, but a lot of times in the moment, everybody gets very flustered. So if you can just grab a bottle cap and put it on, it tamponades the bleeding until the patient can be taken immediately to the OR. So also, this is not something you do and then send the patient home. You do this, and as they're holding pressure with the bottle cap, they're going into an ambulance to the hospital while you're on the phone calling the surgical team and letting them know that this patient is coming. Here are a couple other pictures of this. So this is kind of what this access looked like before. They cleaned it off, and you can see how that scab right there, as the scab sort of lifted off, there's an exposed vessel right there. And they put that bottle cap on it as it started to bleed. And this is in the OR when they took the bottle cap off. They're holding pressure right here, which is the inflow, just to see what that looks like. And I believe I actually have a video of that I can show. So you see right there, you can see that blood, this is the fistula. That's the blood that's coming out that's completely linked to the fistula right there. So that can be a disastrous situation that can actually be life-threatening. So you want to recognize that. All of my dialysis units just have just a plastic baggie of bottle caps. I had my kids collect them so that we can donate them. Any bottle cap works. You know, obviously, if it's smaller and flatter, it'll be less bleeding for the patient, but anything in that situation is better than nothing. So I did want to mention that because it can save lives. And that is pretty much all I had. I'm happy to take questions. I put my contact information on there. If any questions come up as you're in practice, please feel free to reach out. This is something that I'm very passionate about, and I do want to really emphasize just how important and instrumental you all are to the entire dialysis care team. The patients really do value your expertise and your opinion, and you hold incredible potential to guide them in the right direction. So I just want to thank all of you for everything that you do for these patients. It's not always easy, and it's not always recognized. So I just want to underscore how valuable you all are. And I take a look at the chat box, and I'm happy to take any questions at all.
Thank you, Bharvi. A lot of the chat has to do with the contact hour form that I was struggling with a little bit.
Oh, got it. Okay. It's like success. Okay.
Yes, I know. You've got some congratulations on great presentation. The bottle cap, did that initiate in England, in the UK?
Yes, in the UK, that was something that was developed as an initiative there with the kidney. You know, they've got a national system. So their kidney health program developed that initiative and started handing out those keychains basically to all hemodialysis patients that had an access. And then they published that it's actually saved quite a few lives. And since then, this has been several years now. Since then, even at our ASDIN meetings, we've had several people go up and talk about how they used it, even as an interventionalist, you know, that someone was bleeding in the parking lot, and until you could bring them in and kind of figure out what was going on, you just stick a cap on it to make sure that they're not bleeding out heavily, you know. So it is something that you can do so easily, and it really can help buy time and figure out, what's going on, where do I need to get this patient so that, they can actually get it taken care of in an OR.
Do you, for the bottle caps that you collect, do you sterilize them in any way?
No, I mean, we wash them, but they're not sterile. I mean, at that point, they're kind of bleeding out. It's sort of similar to using just gauze that's clean but not sterile. You're just trying to stop that bleeding at that point, and they are going to be going into the OR somewhere. So they will get a washout. They usually have that part of the access resected, so they will get antibiotics and definitive care. But at that point, you're not really worried about sterility.
How would you recommend that a technician who heard about this, Dr. Nege Mala has also talked about
Yes.
this at DTX, our annual conference. Everybody knows Dr. Mala. We all love him.
Yes.
I can just see Mary Lee smiling when I say that. How can a technician introduce this idea into their clinic if they don't already know about it?
So I would start with maybe the charge nurses, but you can always go to the medical director also. I will say that if the medical director of the clinic is not an access person, that they may not have ever heard about it. So I would start with the charge nurse, but there is I think I had the website on here. Yeah, there's a website down here at the bottom, and you can look it up. It's called in England. It's called "Put a Lid on It," and it's a campaign. So you can actually print out from their website the information that they have, and you can take that to the charge nurse and the medical director of your unit and the facility administrator. Essentially, it's really not anything that you have to have approval for, because at that point you're really just doing everything you can to save that patient, so it's not like a protocol that you have to initiate and get approved, but it is something that they would need to know about.
I appreciated your acknowledgement both at the beginning and the end of how important the technicians are to patient care. And it's always a fine line between the fact that the nurses are responsible for the education and the technicians are responsible for reinforcing the education. But are there any specific suggestions you have to help a technician kind of demystify what their nephrologist is saying to them?
To the patient, what the nephrologist
Yes.
is saying to the patient?
To the patient, yeah.
Yeah. So, and this is where I think that you all are so valuable, because, I mean, I'm a nephrologist. I'm guilty of it myself. We come in, we have about 20 minutes to see, 5, 6 patients. We're kind of breezing through, and sometimes you have more time and sometimes you don't. But we come in and out, and then you all are there with them. And I would just start by kind of, lightheartedly just saying, was there anything about that you didn't understand, that you maybe have questions about? I always tell people, even as I'm interacting, because I interact with people in the access center who aren't necessarily my patients, that I don't see in the dialysis unit. And I usually tell them, look, I may not know the answer, but I can always find out, or I can reach out to your doctor and let them know what your questions are so that I can pass that along for you. And that typically helps people open up a little bit. When you approach it that way, they tend to feel more comfortable to just kind of ask you their questions. And I also tell them, that there really are no dumb questions, that I've asked many a question in my career and in my lifetime that many people have laughed in the room, but I truly didn't know the answer to it. So I tell them that as well. And I think that helps also. And they also, as you see them more often, you build that rapport with each patient, that they kind of start trusting you and trusting that the information they tell you will only be used in kind of a confidential way.
Well, that's a great suggestion. I don't see any other questions in the in the chat, and we still have everybody who signed in for this webinar is still on. So I want to thank you, Bharvi, for just a very knowledgeable, accessible presentation. And this whole put a lid on it UK concept is something that I think every single one of our technicians could introduce into their clinic. And I think all it takes is for one access to bleed out for people to understand, right?
Yes, it just takes one. It really does. And you feel so awful and you never want it to happen to anybody again. And it is preventable, you know? So that's why I put it in here. I know it wasn't really in the purview of of the objectives, but I put it in almost every single one of my access talks because it's so important and it's something so simple that everybody can do.
That's great. Well, thank you very much. For those of you who logged in on time, we will get your contact hours to you next week. We are also going to have this posted in the NANT Learning Library. It is free to NANT members, especially if you're looking for an extra credit or two before you go for recertification. And I also want to tell you that if you weren't able to attend DTX 42, where Dr. Mala spoke and other members of ASDN spoke, you can purchase the webinars for viewing and earn more credits for your certification, recertification. So, Bharvi, thank you so much. Oh, Wilmer says he's looking forward to seeing you at VASA next week.
Oh, perfect. Perfect.
Yes. So, and Hilda, thanks you for your presentation. Christine, Wilmer is from Peru, South America. So thank you all. And Bharvi, if you just want to stay on for a second, that would be awesome. I'm